Okay, hello, good evening. Welcome to 2022's first installment of Ask an Expert. Tonight, our expert will be answering the questions, what is harm reduction and why is it good for public health? My name's Amanda, and I will be your facilitator this evening, as well as the disembodied voice of, as well as the disembodied voice of the monitoring the questions and the chat throughout the evening and the discussion. I'm also the program coordinator for BCH's PILLAR Program. And for those of you not familiar with us, we help get folks connected to treatment for substance use disorders or the management of chronic pain without narcotics. Check us out, bch.org/PILLAR. I'd like to go over the format for tonight's lecture. The lecture portion will last about 40 or so minutes, and then we will use the remaining time for questions. Before we get any further into that, though, I do want to acknowledge that this can be kind of a touchy subject. Generally, folks have a lot of feelings around harm reduction and things we'll be discussing tonight. So that being said, we want to keep this appropriate, so please type any questions or thoughts into the chat box to the right of your screen. Please keep it short, general, and respectful. And we will get to questions as time allows. If we don't get to yours or there's something that comes up after tonight's discussion, please feel free to reach out to myself or to our speaker. There will be resource slides at the end of the presentation that will have contact info for both Madeline and I. So with that, thank you all so much as well for tuning in, whether you're joining us live tonight or watching the recording. We're so appreciative that you are showing support for not only our programming, but just to learn more about really sometimes taboo subjects and how you can help support the public health of your community. Because you're all taking time out of your day and out of your lives to tune in, I want to be transparent with you all and set an expectation for the evening, which I generally try to do up front. And as always, if you've joined us for lectures before, I really do try to help folks understand that these are really big questions and they're not easy answers. Tonight is no different. This isn't going to be an easy answer to the questions of addiction, mental health, trauma, pain. But what it will be is how to potentially get started on journeys to address all of those things I just mentioned, and a message of hope that there is support out there. Recovery is possible, and you matter enough to access the folks that want to help make better healthcare choices, help make life more fulfilling and healthier, all of the things that we hope you can find through our lecture tonight and even our programming if it goes further for yourself or someone you love. So, with all that being said, I would like to introduce tonight's speaker. Please join me in welcoming Madeline Evanoff from Boulder County Public Health. I am going to turn it over to Madeline. She'll talk a little bit more about herself and her experience, and then we will dive right into what is harm reduction. So thanks everyone so much, and please feel free to enter any questions or thoughts on discussion in the chat box throughout tonight's presentation, or you can certainly save them till the end. So take it away, Madeline.
Wonderful. Thank you so much, Amanda. And I just want to second what Amanda said. I am so grateful to be here. Thank you all for joining and listening, whether it's tonight or at some point in time in the future. So my name is Madeline Evanoff, and my pronouns are she, her, hers. I am a harm reduction specialist with the Works program at Boulder County Public Health. And we are a harm reduction and syringe service program that serves Boulder County. Personally, just a little bit about myself. I have over 10 years of experience working within Boulder County with vulnerable populations, including those who are living with and at risk of acquiring HIV and hepatitis C, people who use drugs, those experiencing homelessness, as well as folks who are incarcerated. So just to jump into a little bit about what we're going to be talking about tonight. So I want to start us out by just providing a really basic definition of what harm reduction is, how it's utilized in public health. We'll move into harm reduction specifically as it applies for drug use and substance use. And then I want to end the evening talking about the program that we have here in Boulder County, the Works program, that has been around for over 30 years now. And really the purpose of that is for folks to know what we do, how we support the community, and to provide you hopefully with a resource to encourage people to seek services and resources if they need it through our programming. Learning objectives, really what I'm wanting for people is for all of you to walk away with a better understanding of harm reduction as it relates to people who use drugs. Maybe increase or just solidify whatever knowledge you have already about substance use disorder. Be able to maybe recall on your own an example of how harm reduction could be used for people who use drugs. And then have a basic understanding of the significance of syringe access, not just for people who use drugs, but for a community, for the health of an entire community. So an overview of harm reduction. So as human beings, we all engage in behaviors that can put us at risk of harm, right? Some of these behaviors are legal, so there's less stigma attached to them. Some of these behaviors are illegal, and so there tends to be quite a bit of stigma attached to them. The reality is that as human beings living our lives, we encounter risk on a daily basis. And what public health has tried to do over the decades is apply different types of harm reduction programming to help lessen the risk associated with these behaviors that people engage in, right? So some examples of that might be using condoms during sex, right? Using contraceptives during sex, wearing a helmet when you're riding a bike, wearing a seatbelt, using a nicotine patch instead of smoking cigarettes. We know that reduces harm. And then some things that we might all be a little too familiar with at this point in time would be like wearing a mask or using vaccines, right? So all of these are ways to help reduce the risk of different behaviors. And really the main purpose of this is just acknowledging the fact that we all utilize harm reduction throughout our daily lives. We just don't think a whole lot about it, right? We all probably wore a seatbelt. Hopefully we all have airbags in our cars. So these are things that we're just used to doing to help keep ourselves safer. And there are things also that public health in general has recognized the importance of and has implemented programming around. So this certainly holds true for harm reduction for people who use drugs as well. This is really just basically a set of strategies that people who use drugs can utilize to help reduce the risk and harm that can be associated with their substance use. So one way to frame this is to look at things through more of a macro lens. So we can look at things like national policy and state law that can impact the safety of people who use drugs. So examples of that would be the federal government actually recently overturned a ban that had been put in place in 1988 on funding for harm reduction programming. So now the federal government is actually able to provide funding for programs like ours, and with more programming reaching people who use drugs, the risk of HIV, hepatitis C, death from overdose, harm from overdose, we're going to see those things decrease, right? Another example would be the state of Colorado has legalized syringe access. So people who utilize harm reduction services here do not have to worry about being profiled and potentially getting a criminal charge for accessing a healthcare service, right? So those are some more of the looking at it in a larger picture. Harm reduction oftentimes is most powerful when you're looking at it through that micro lens, though. And what's so important about harm reduction is recognizing that everybody who comes through our doors, most of these people with a substance use disorder, right? Every one of those people is a unique, interesting, dynamic human being that has so much more to them than just their substance use. And by engaging with them in a way that acknowledges that and recognizes that, we're giving them back the dignity that we all deserve as human beings, right? So this really feeds into the harm reduction theory. There's a couple different pieces of this. So let's start with the spectrum of strategies. With harm reduction, part of really focusing on that participant-centered piece and recognizing how everybody is an individual is knowing that not one thing is going to work for every person, right? So we want to have a whole buffet of safety options that people can choose from. And we are going to, give the participants that come into our program that leadership and autonomy to be able to tell us, hey, this and this are really realistic for me and I can do this. I know I can. That's empowering for them. But you know what? These other options here, it's not realistic for me right now. And what's great about that is we know that with behavior change doesn't come from us telling people that they should change or telling people what they should do. It comes from, that ability for us to recognize what's possible and taking ownership of that. And that's so much a part of people building skills to really treat themselves with respect and maybe enter into a place where they can start thinking about recovery. So that's one part of the harm reduction theory. If you look at a group of people, most of us will use drugs at some point in time in our life, right? Experiment with it, use them socially, whatever that might be. The vast majority of people who use drugs, even drugs that we deem as being highly addictive, like meth and heroin, do not end up with a substance use disorder, right? So what we know about that small subset of people that do is that they are much more likely to have encountered trauma at some point in time in their life, right? Trauma is relative, so my trauma is not going to be the same as yours. And it doesn't matter what the trauma was, but what we know about trauma is that it primes the brain. It makes you more susceptible. It makes the brain more susceptible to developing a substance use disorder. And trauma can be experienced on an individual level. Trauma also can be experienced on a group level. So when we look at things in our society that really negatively impact groups of people, such as the, discrimination and oppression that different groups of people have faced based on their race, their culture, their gender identity, their sexual orientation. These are traumas that entire communities experience together, right? So trauma can also be collective as well. Knowing how trauma impacts substance use disorder is a really, really big part of understanding harm reduction and how we can really serve people who are dealing with substance use disorder as effectively as possible. And I think the last thing on this slide that I'd really like to touch on is just the fact that, harm reduction is about being pragmatic and realistic. And what we know is that people use drugs, and no amount of criminalizing drugs or substances is going to change that. People have been using drugs for, there's records of it for over 8,000 years. This is something that's been a long part of our history. It's not going anywhere. And so harm reduction is not enabling people. It's recognizing that this is a behavior, just like so many other behaviors that human beings engage in, that carries risk. So why not offer people opportunities to lessen that risk?
Madeline, anecdotally, how many of the participants you see would you say have experienced trauma? What percentage would you guess?
Oh gosh, that is an incredibly challenging question.
Sorry.
No, it's a fantastic question. It is a very challenging question in that it will be incredibly anecdotal. I would say that in my day-to-day work, it is incredibly uncommon for me to encounter somebody who has not experienced trauma.
Sure. Thank you.
Yeah. So the majority, by far. Yeah. So there's been a little bit of a snafu with our video sharing. So these slides will certainly be accessible to people should they want to follow up on some of the resources in here.
Yes, absolutely. And folks can go to the links provided on the slide deck. Like I mentioned earlier, my contact info for Amanda will be at the end, so please don't hesitate to reach out if you would like a copy of the slide deck, and you can absolutely access the videos from there.
Yes. Wonderful. So this video here, I'll just mention briefly, it's a really nice, it was done locally, which is always great to support. And it's just a really nice, brief, easy way to conceptualize the science behind substance use disorder. And put really briefly, just an overview of how different mental health conditions and trauma can really prime the brain chemically to be more susceptible to substance use disorder. And so I think that it does do a good job of breaking down that stigma that can be associated with substance use disorder, and the perception that's still out there, unfortunately, that it's a moral failing, right? And we know that that's not the case. The science is there to prove it. So I would highly recommend following up and watching this video just to break down a bit of that science for you. So next, looking into harm reduction and substance use and the history of substance use, we need to know that what is legal and illegal throughout our history and, globally, but I'm going to really focus in on the United States here, has been fluid, right? And the importance of this and knowing this and knowing a little bit of history behind substances and why some are illegal and some are legal in our communities now is knowing how far back these laws go and how rooted in racism these substance laws were initially. And I think that sometimes we can, a lot of us don't have the education around it. And, we're just brought up in a culture where certain drugs are more acceptable than others. Certain drugs are legal and others aren't. And it's easy to not question that, particularly since the history really isn't taught, right? So some examples of this would be cocaine was actually initially made illegal in the early 1900s because of its association with the Black community, African American community. Opium was originally made illegal in the late 1800s because of its association with Chinese immigrants. And marijuana was actually initially made illegal in the 1910s, 1920s because of its association with Mexican migrant workers. And so these laws came into place not because there had been, robust amount of of, research and scientific evidence that pointed at these substances being more dangerous and more highly addictive, these laws came into place because they were a way to further oppress and create othering of Black, Indigenous, and people of color communities here in the United States. So looking a little bit further into this, this slide here just covers a couple of different statistics that we could look at and the ways that substances really disproportionately impact Black, Indigenous, and people of color communities here in the United States. And a lot of it does go back to the racist criminalization and then subsequent incarceration rates that have happened within these communities. So I'm bummed that I can't show this video to you all. It's really wonderful. These are some great resources just for getting a little bit more information, a little bit more education on racialized drug policy. And and more recently, that was, the drug war that started in the early 1970s and has continued. But the Drug Policy Alliance is an organization that does really amazing work with this and provides great, scientifically backed education. And one really great, super short video that just hits all of the main points of the drug war and how it has impacted already marginalized communities is this top link, What is the Drug War? So I would really recommend watching that. And then another great resource is Dr. Carl Hart. He's a neuroscientist and psychologist with Columbia University. He identifies as a Black man with a criminal past and also a current drug user. And he speaks very well to, how substances have impacted different Black, Indigenous, and people of color communities here in the United States. So we're going to shift gears here a little bit. We're going to talk about the history of syringe service programs. So, syringe service programs have been around for decades now, and they've been around for such a long time that there's been able to, be a real wealth of evidence that has built up for just how effective they are. And we'll talk a little bit more in a moment about what types of things they really can assist with from a public health perspective. But before jumping into the history, I think it's so important to give credit where credit is due. And syringe service programs were actually started by people who use drugs for people who use drugs. And this is because, folks that are dealing with substance use disorder have often been stigmatized and marginalized. And so they have needed to take it upon themselves to build these programs initially to help care for their own communities. And after doing so, that is when, there was some real understanding and recognition of how powerful these programs are, how effective they are at curbing infectious disease and overdose risk, among many other things. So they began in the 1970s and early 80s in the Netherlands, and they actually started at first in response to the hepatitis B virus and some outbreaks that were happening. And then the first underground syringe service programs popped up here in the United States in the early 1980s, and that was in response to HIV. So, I talked about that federal ban on syringe service programs that hit in 1988. And our first more formal syringe service program in the United States started in 1988 in Tacoma, Washington. And Boulder County, it may not surprise some people, we were actually the third syringe service program to start up in 1989. So the WORKS program that we'll be talking about in a bit more detail here, it's been up and running for over 30 years. We have a good history here. One of the biggest things that syringe service programs assist with is curbing the viral hepatitis and HIV rates within communities of people who use drugs, but also what we know from, public health surveillance is when, viral hepatitis and HIV rates get high enough in people who use drugs, those infections do start to bleed out into the community at large, right? So this is not just in the best interest of people who use drugs, but in the best interest of communities as a whole. And as you can see, some of these statistics are actually pretty overwhelming. The 60 to 90% of people who inject drugs will have hepatitis C within 5 years of initiation of their injection drug use. That is a profound number of people who have a viral infection that can be deadly, that is also preventable, right? And that's part of what is so impactful. And I do want to throw out, so syringe service programs, after all these decades of research, what they've been able to see is that they do, statistically, collectively lower the risk of HIV and viral hepatitis by about 50% in the population of people who use drugs, which is a pretty significant amount. This map here, I just find this interesting. It shows where syringe service programs are here in the United States. And I did mention at the beginning of our presentation that syringe service is legal here in Colorado. That is not the case in all states in the United States. And as you can see, the West and Midwest is pretty void of services for people who are using drugs. And we do every year have people come from outside of Colorado. We have people who drive from Kansas, Nebraska, Utah to be able to get sterile supplies to use substances for themselves and their communities so that they are less likely to get infected with HIV or viral hepatitis, less likely to die of overdose. And this is a group of people that is oftentimes judged for not caring about themselves, not caring about their health, not caring about their safety. And I don't know many people personally that would make a 16-hour round trip to collect supplies, medical supplies, for a service that they can't access. Something that comes up a lot, and it still comes up a lot because harm reduction and syringe service can be something that is still really controversial. And something that pops up a lot for folks is, isn't this enabling people? Isn't this something that's just allowing people to keep using? And I love this statistic. So the CDC did a comprehensive literature review. And this was back in 2017. But what they were able to discern from this was people who use syringe access programs, who are injecting drugs, they are 5 times more likely to enter into treatment for substance use disorder and more likely to reduce or stop injecting than people who inject drugs who do not use syringe access programs. And this really goes to speak to how when you have a one-on-one interaction with somebody where you are treating that person like a human being and you're giving, an opportunity to build that person up, to build, their self-confidence and their self-esteem up and break down, chip away a little bit at that shame, how much impact that can have on somebody stepping towards recovery. And then I'm just going to let folks take a moment to read this slide here. And actually, I might read it out loud just because this is a quote from one of our participants specific to the Works program. And this person wrote, "I was in Utah for 7 years and I was not even treated as a person there. And I couldn't get an HIV test to save my life. The level of guilt and shame I felt made me want to use more. What I like about Boulder is that it's out in the open. I don't have to hide. I have a safe place to go. The more face-to-face time I get with people like you, the Works team members, and a link with services, it helps to reduce my usage. I have lost all relationships and been to dark places I can't even talk about. I am going into treatment tomorrow. So just,
Yay.
I know, right? It is. It's just, and these are stories that we do see, and we do see regularly, and it's really what feeds all of us, myself and my coworkers, with the Works program is stories like this.
We've got a question
Of
about
course.
the Works program.
Yeah.
And you may get to this, or, we may talk about it a little more at the end when we discuss resources. But one of our audience members is wondering, is the Works program a syringe disposal site for anyone in the public?
That is a great question. Thank you so much for asking. So, unfortunately, we are not. So anybody who is using substances via injection use is able to dispose of their syringes with us within one of our offices, but we don't have the capacity to take syringes back within one of our offices. With that being said, there are 3 24/7 outdoor syringe kiosks that are within Boulder County. There's one in Longmont and 2 in Boulder. And I'm trying to think of the best way to get information out to this individual and people that might want it. I know, so on our website, which these slides does have our Works program website, it does have the address for the outdoor kiosks. So that's part of it. And then I will, I'll make sure to add a note in there before the slides go out, just to make sure that the locations of all those kiosks are on there. So within the office setting, no. Outside of the office at these kiosks, yes.
Perfect. Thank you.
Yes, absolutely. So we've talked a lot about stigma. We've talked a lot about, shame and people with substance use disorder experiencing these things and how detrimental that is to folks. And I really want for all of you to be able to walk away feeling like you have something tangible that you can take that can make an impact. And the one thing that I'd like to offer up for folks is to be really aware of your language. And it seems like such a simple thing. But language being, our primary communication with one another, it's very, very powerful. And it has the ability to really beat somebody down, and further stigmatize and shame. And what's beautiful about it is it also has the ability to really build somebody up and make them feel valued and appreciated, and recognize that you're coming from a place of compassion and caring. So these are just some basic examples that I have up here. And these are language examples that I still hear today, that I oftentimes hear, out and about in the community. Even other professionals will use these terms, and they're not meant in a negative way. Oftentimes when people use like addict or substance abuse or somebody staying clean, they don't mean to break somebody down. They don't mean to further stigmatize. But I want to give some options for some more compassionate language. So anytime that we talk about people who are using substances, we want to use person-first language. So a person who uses drugs, a person who injects drugs, a person who snorts drugs, a person with substance use disorder, right? So we're recognizing that this is a part of what somebody's experiencing, but it is not their identity, right? I don't think any of us would want to be stripped down and identified as the one thing that we are most shameful of. And so doing this allows people to have a broader human identity outside of that substance use. And we hear clean a lot. Somebody's staying clean. Somebody has a clean UA. So changing that language to a person who is, modifying their drug use. Somebody who is abstaining from substance use. Somebody, instead of relapsing, somebody who has started using again, right? We now know that people go in and out of cycles of substance use quite a few times before recovery is successful. Oftentimes people will, right? So not stigmatizing that journey that people go on. And then, when we talk about medication for addiction treatment, things like Suboxone or methadone or Vivitrol, referring to that as medication for addiction treatment, right? This is a health issue. Not talking about replacement or substitution therapy. It's not the same thing. This is somebody who's taking charge of their health. They're taking a medication every day to help treat a medical condition, just like somebody would for a heart condition or diabetes, right? And then the last piece of this before we really switch into the works program and dive a bit more into what we do. I just want to leave folks with a couple quotes that really help ground me in the work that I do. So the opposite of addiction isn't sobriety, it's connection, right? When people are using substances, and they're using substances problematically, right? So something that we would consider a substance use disorder. They're lacking that connection, right? They're seeking. They're trying to fulfill something that isn't there, and it's a coping strategy that unfortunately short term works really well, and long term is really catastrophic, right? So that connection, and we all have the power to do this. We all have the power to make that connection with people, and show that radical acceptance and that compassion and help break that down. Not asking what's wrong with you, but what's happened to you. And that's really circling back to that trauma-informed care lens, knowing that the vast majority of people with a substance use disorder have a lot of pain from trauma that's been experienced. And then I just want to end with a brief exercise. So I want us all to just take a moment and just think of a time that you have felt shame about something, and you felt so much shame about this thing that you've kept it a secret. That feeling is so often what people have inside when they are walking through our doors for service. When you're meeting somebody on the street, right, with a substance use disorder. So not all of us are going to be able to relate to substance use disorder. Some of us are going to get really frustrated by it. And that's understandable, but all of us can relate to that feeling of shame. That's a very human experience. So just holding that in mind when we're really trying to come from that place of compassion and acceptance. So I am going to really change gears here. We are moving into the works program, what we do. So as I mentioned, we are a public health run syringe service program, and we've been around a long time. So during that period of time, from 1989 to now, we've built some really phenomenal relationships within our community with other community organizations and agencies, right? One of them being Boulder Community Health and the PILLAR Program. It's wonderful to have a place where we can send folks who are ready for recovery to be able to get assistance walking through the different steps and what that's going to look like for them, what needs they have. We work really closely with Recovery Cafe Longmont, which is a wonderful organization, very low barrier recovery support programming within Longmont. We work really closely with the Boulder Sheriff's Office. We actually provide programming within the Boulder County Jail. So we offer HIV and hepatitis C rapid testing to people that are housed in the jail, as well as Narcan training. And the jail actually provides Narcan to people who are diagnosed with an opioid use disorder and are leaving the jail. We know folks are at heightened risk of overdose.
Why is that, time. Madeline?
That's a good question. So anytime that somebody is, just looking at opioids specifically for a moment, anytime that somebody is accustomed to having opioids on board, right? their body's gotten used to having opioids, and then they stop using, they are going from having a really high tolerance towards opioids to then having a very low tolerance or a lower tolerance, right, after not using. So then when people begin using again, a lot of times they will start using the same amount of substance that they were used to using previously. And since their tolerance has been lowered, it puts them at a very heightened risk for overdose. So yeah, we work really closely in the community with lots of different people, lots of different agencies, and lots of agencies that support recovery so that we can help people along in that path when and if they are ready for it, right? So we provide all of the supplies and equipment that people need, not only for safer injection, but also for snorting and smoking substances. And this can seem very controversial to people. So I just want to take a moment to break down why it might be that we offer that. So when somebody is injecting a drug, they are breaking their skin, right? When you break the skin, not only are you at risk if you share equipment for transmitting HIV or viral hepatitis, but you're also at risk of getting some pretty severe bacterial infections. So if somebody can snort or smoke a drug rather than inject it, they are going to be at much less risk of getting these infections. You also are going to be at much lower risk of overdosing. So if somebody is snorting or smoking an opioid rather than injecting it, they are at much lower risk of overdose. So that's why we provide those supplies. We do a lot of education with our folks about, safer vein health, wound care, overdose prevention. We provide fentanyl test strips and Narcan to people. We do HIV and hepatitis C testing that's rapid. We provide street outreach, so we go within our communities and we deliver services to people who are experiencing homelessness right there where they're at. A huge part of what we do is linking people to referrals, whether that's for, housing, food banks, treatment resources, a whole host of different things, mental health needs. That's a big part of what we do. And then our program being, is anonymous, it's free, and anybody who uses drugs can access it. Anybody, whether it's somebody who uses occasionally, whether it's somebody with a substance use disorder, whether you smoke, snort, or inject, anybody who uses drugs can access our services. So just to cover a couple laws that relate to the Works program. So our program is legal in the state of Colorado, right? We're in a county-approved certified syringe exchange program. Because of that, our participants are actually exempt from drug paraphernalia charges. So we have little identification cards that we give out to people who get our programming, and these identification cards provide a unique ID that these people use every time they come in for service. So it's how we track what we're giving to somebody, how many syringes they're giving back to us, what referrals we're giving to them. And it's also a way to prove that they are in a county approved, they're receiving services from a county approved certified syringe exchange program. So they're exempt from paraphernalia charges if they get stopped by law enforcement. In the state of Colorado, anybody who administers Narcan is covered by the Good Samaritan law. So if you think somebody's overdosing, but you're not sure, it could be a different health event, but it looks like an overdose, rest assured that you are protected under our Good Samaritan laws.
If it is not an overdose, is administering Narcan going to do anything to the person that you're giving it to?
That is a great question. Narcan is an incredibly safe medication. So if somebody has used multiple substances, a different substance other than opioids, is having a whole different health event that has nothing to do with substance use, it just isn't going to do anything, but it absolutely will not hurt them.
Perfect. Thank you.
And this is just an example of those legal protection cards that we give out to our participants. So here in Colorado, anybody should be able to walk into any pharmacy and get Narcan without a prescription, right? I say should because not all pharmacies, unfortunately, are entirely educated about this law, but it is something that we all have a right to. If you have Medicaid or Medicare, you can receive Narcan for free from a pharmacy, which is great. If you don't, then the copay just kind of depends on what your insurance is. What I would like to say is the most important law to cover and just hit on is one that really protects folks in case of an overdose. And what this law is the person who is overdosing, experiencing an overdose event, and the person who calls to report this overdose event. Those two entities are protected from criminal charges when EMS is called during a drug or alcohol overdose event, right? So it doesn't matter if there's, heroin or opioids or, meth on scene, or if it's people who are, under the age drinking. That person who's called and stays with the person who's overdosed and the person who's overdosed, those two people are going to be protected from criminal charges. And that is so important for people to know because we still see hesitation calling about overdoses. And we just are seeing too many people die from overdoses for there to be a hesitation there. So we need people to be aware of this law.
It goes along with the recommendation too of don't use alone.
Yes.
Right? Because
absolutely,
if that overdose event occurs, you're at least if one person stays on scene that can report it, you're not going to hit legal trouble, right?
Absolutely. Absolutely. Yes. And then just wrapping up, sharing a little bit about where we're located. We have 3 offices within Boulder, City of Boulder, and we have one in City of Longmont and one in City of Lafayette. And excuse me, it's actually down to 2 in City of Boulder. I'm so used to us having 3. It's down to 2. We work really closely with 2 community partners, mental health partners in Boulder County AIDS Project. And they provide a satellite service through us. So we provide all the materials to them, but their agencies actually provide the service out of those buildings, which is just, we couldn't do what we do without them. And then we have a public health office in Longmont and one that is out of the Clinica Family Health building in Lafayette that also provides syringe service. So I think...
So Madeleine's contact info is on this slide.
Oh, yes, I can go back. My contact info is there. If anybody is interested in having an individual or group level Narcan training or fentanyl test strip training, or you have any other information about what supplies we offer or, how to work with harm reduction with somebody in your life that's using, please feel free to reach out.
Madeleine, is it true that the walk-in crisis center had to cut their hours due to staffing? I think Mental Health Partners did say that they've been understaffed for the 24/7 service.
They did. So they have been understaffed. What I will say is luckily that has not impacted our programming there. So they still have people 24/7 that are there at the desk assisting with the withdrawal management portion of their facility.
Oh, I see.
So the crisis center had to cut hours, but that withdrawal management piece is still open 24/7.
Okay, good to know. Great question. And we've got just about 10 more minutes left, so we'll just give folks a second to kind of digest all of that fabulous information that you provided us and see if there's any other questions or thoughts.
Absolutely. And as I said, please feel free to reach out individually as well.
Yeah, of course. And I think there's a resource slide with, like I mentioned, with my contact info. if you want these slides, shoot me an email. You can also go to the BCH YouTube channel and find this recording and watch it all again if you've joined us live tonight. Not getting any from the audience. I had a question.
Yeah.
Which really you and I have talked about before and really seems to be in the spirit of harm reduction. So I was wondering if you could chat a little bit about folks that you're seeing that, they're using pretty heavily, but recovery just isn't on their radar right now.
Yeah.
That not everyone that you or your team interact with has recovery as the goal. So
Absolutely.
I'm just wondering, how do you work within those situations? How do you keep supporting folks that are making that decision to keep using and keep using at the rate that they have been, however that may look?
Absolutely. No, thank you for that. I think it's a really important topic to bridge. Recovery is not in everybody's, part of everybody's goals. And, frankly, it feels really unrealistic for a lot of people, given what a lot of our participants are dealing with. It's something that would be hard for anybody to start thinking about, right? When you're worried about where you're going to get food, where you're going to have, shelter and stay warm. So harm reduction, really like the basic principles that participant-centered piece, right? And being participant-centered recognizes that whatever goal our, the person in front of us has, that's the goal that we're working as an ally with that person to achieve, right? So that goal might be really simple. It might be, I don't want to die from overdose, but I'm not going to change anything about my substance use. I just don't want to die from overdose. Okay, that's great. We can absolutely work with that, right? So we can get you trained with fentanyl test strips. We can get you trained with Narcan. We can make sure you walk out with that. We can talk about what puts you at higher risk of an overdose. We can brainstorm ways that are realistic for you to reduce your risk. And the reality is that some people who use substances are never going to enter into recovery.
Right.
But as a human being, they still deserve to live their best life possible.
Sure. Great. Thank you. And I'm sorry, someone threw in the chat that they don't see my email on this contact slide. I apologize. And when I'm trying to respond with it in the chat, it's not letting me because it's reading it as a link. So I will just spell it out because my last name is quite a mouthful. It's Wroblewski. So my email is first initial last name at bch.org. So it's AWROBLEWSKI@bch.org. Oh, yeah. Nope. Just our website is up there. Okay. My contact info is also on the website, bch.org/pillar. But, yeah, that's my direct email is first initial last name at bch.org. So apologies for that. And then we have another question. We have a couple more. We've got about 7 minutes left, just to be mindful of time. Someone writes, one thing that can be difficult for medical providers are those who have been repeat Narcan users. So they're seeing the same folks for overdose multiple times. How would you approach that with providers? What would be what kind of wisdom would you impart?
Oh,
on
yeah.
those
No,
folks?
that's a really great question. And it's, we actually have a lot of our participants will walk in and they'll say, yeah, I went to this ED and they know me real well there, and so it's something that we see, that we talk to folks about. And this is what I would say. I would say that when you meet somebody with acceptance for their substance use, right? And compassion, it's going to go a long way. So if you have somebody coming in and it's, the third time that there's been an overdose reversal, saying, hey, do you know about the Works program? What are you doing right now to work on this overdose risk? What are your resources? Who are you talking to? Where are you getting your education? Not going straight to, why do you keep doing this? Here's some recovery resources, because a lot of times people aren't in that mindset, right? So being able to acknowledge, okay, you're using, I'm not judging you for using, I just don't want you to overdose and die. So what can we do as a team to reduce the risk of that happening?
Right. To keep you safe.
Yeah.
And something that another one of your colleagues said one time, which I'll never forget, is can't help them if they're dead.
Nope.
So if we keep having that conversation of, well, what are you doing to stay safe? Maybe at some point they will make that decision and will, be engaging in less risky activities, or at some point get into recovery if that's where the path leads. And
I actually, and I know we're short on time, but I did have somebody say something to me really powerful once, and it was one of my instructors for some substance use classes I was taking, and she said she had a client who kept, using in a way where, they were overdosing over and over again. And she asked this person, what is so painful that you don't care if you die? And that has just really stuck with me, because I think so often people are not actively suicidal, but what is that pain? What is that hurt that's there that's so powerful that you don't care?
Right. That's a really great perspective, because it could definitely be a passive suicide, right? And people just not wanting to live in the pain that they've got. We had someone that had to hop off just a few minutes early, but says, thank you so much for this presentation. And we've got about 4 more minutes. We've got one participant wondering what you and the Works team are seeing locally. Oh, and I'm sorry, before I go further, just to back up to the medical provider question, if folks are being seen at the Foothills Emergency Department for BCH, we do Suboxone induction there. So if somebody is ready to, even if they're not being seen for an overdose, it does not matter if you are, to the phase where you're done actively using and you are ready to take a step onto a path of recovery, you can, 24 hours a day, 7 days a week, the BCH Foothills ED can, if you're appropriate and it's safe, can start you on Suboxone. But we have one person wondering locally about the street drugs, namely the fentanyl or the, I know there's stuff besides fentanyl that's moving in from the coasts that we've seen pretty rarely, but it was the same with fentanyl until it moved right on in. So namely they mentioned blue pills. Yes, that's a great question.
Can you explain
what those are?
Yeah, absolutely. So there are counterfeit oxycodone pills that people refer to as blues, and those have really taken over this area, and they are a mixture of different substances. We're not really sure what, but oftentimes contain some percentage of fentanyl, and because of how irregular the quality is, that's what makes them so dangerous, right? It can be a really poor quality, not a whole lot of fentanyl there. Most often what we're seeing is that they are pretty strong. They do certainly have a strong, fentanyl or a strong fentanyl analog in there. And that has been what we're seeing the most of right now as far as opioids are concerned. I actually, there are some folks who are still using heroin who are accessing our services. I've had a couple people talk to me. Their drug of choice is heroin, and they are having a hard time finding heroin. These pills are really taking over the opioid scene in our area. And then, there have been some other drugs that have been mentioned more recently, particularly on the coast. There's a large animal tranquilizer called xylazine and some, designer benzos and such that have been a bit more popular on the coast. We have not yet seen those hit our area here.
Okay.
Yeah.
Good to know. Well, thank you for all of that explanation and for the whole thing. We're just coming right up on 7 p.m. and we'll go ahead and end it there to be mindful and respectful of everyone's time. But let me thank you so much again,
Oh gosh, it
Madeline.
was wonderful. Thank you.
Thank you to the Works program. We're so grateful at Pillar and BCH to work with you all, and are very grateful that your program exists and has for the last, 33 years now?
Yep.
Fantastic. Once again, if folks are, wanting more information, wanting to do some one-on-one, question and answer sessions, or you want the slides, you have any questions about substance use disorders, treatment, please don't hesitate to reach out. This is what we're here for. We hope that we can be helpful and support people where they're at. Thank you all so much for joining us, again, either today or on the recording. My last request would just be if you could go to the Google Forms link that's right under this YouTube video, whether you've watched the live stream or the recording, and please fill out our post-lecture survey. We want to hear from you. Tell us how we did. Give us ideas for future lectures. This is for you all to learn more and to be a part of the conversation in the community. Plus, we are grant funded, so it also really helps when we can show our impact. So please fill out the survey. It'll take just about a minute and a half, and we greatly appreciate it. Thank you all for tuning in, and thank you, Madeline.
Oh, thank you.